Lisa.
I asked for you.
No worry. Thank you very much, Mort, for giving me another opportunity to express free thoughts. I think one of the interesting things about these meetings is that, in a way, it's a meeting where you don't have constraints of ideas and so forth, and I have certainly to congratulate you by being innovative, which is what this field needs today. I'm going to go quickly into a way of thinking. I wouldn't put this any further than saying that cardiovascular disease is an epidemic. The difference between cancer and cardiovascular disease is that cancer, either you have it or you don't. Atherosclerotic disease, everybody has it. And the question is the degree, and that's what makes things difficult. In other words, when you talk about risk factors, you have to see in that context. Cancer is there or is not. And I think this is actually the way I like to talk first. First of all, there is epidemiology and change. Let me just do. First question is epidemiology and change in emphasis. This is the reality. The reality is cardiovascular disease, coronary disease, 1990, 2020. This is non-Western countries. These are Western countries. Life has been prolonged 6 years in 3 decades, 4 of them related to better treatments of myocardial infarction. The problem is, as life is being prolonged, we are not preventing the disease, which is going up at a tremendous speed. And this is something that is really alarming. And the question is why this is happening. I will say to you that in the center of all of this is actually the metabolic syndrome. When you start looking at what is happening, and this is an example, 1990, 2000, this is the same methodology. More than 20% of a given population who is obese in 1990, look in 2000, the country is getting purple. Now, if you now look at diabetes, more than 6% of a region being diabetics, you see what the change is in just 10 years. And again, it's the same methodology. And this is absolutely alarming to the point that the World Health Organization actually has a meeting in about 3 weeks, which I will be there, because this is absolutely alarming. It's not just in the United States, it's actually all over the world. Now, the problem is in children, and that's what I want to emphasize. Although this organization is looking at people over the age of 45, I'd like to make some kind of a few statements today that if we don't go earlier, we are going to miss the boat here. These are children by the Haynes study, which many of you know, where low HDL in children between 12 and 19 years in this country being low in 45%, hypertriglyceridemia in 30% being high, almost diabetes, hyperglycemia 5%, central obesity in this country 22% of children, and now you have hypertension. Now, the figures, if you go back 15 years ago, were much, much lower. So the problem that we are facing right now is an epidemic that really begins in childhood. And we cannot lose track of that because that's the root of the problem. So having said that, let me now evolve into at least my way of thinking on this very significant issue. This, to me, explains how we are moving from target to target in the last 5 years. And I'd like to make a few points. First, we move from the high-risk plaque, let's call vulnerable plaque, to the high-risk symptomatic patient, because that's really how all began these discussions began. And I'd like to say to you that this is a plaque that is very troublesome, but let me make one point. The concept of vulnerable plaque or high-risk plaque is an autopsy concept. And let's be clear, a patient dies, you do an autopsy, Erling Falken says that plaque has a clot, there is a vulnerable plaque here, I see fat. If you go prospectively with imaging, it's a completely different story because you see many plaques that you would call the same. And that's very important that we know historically. This began from autopsy, but it's not when you go prospectively, it's much more complex. And therefore, here we have the patient who presents with acute coronary syndromes, chronic atherothrombotic disease or coronary artery disease equivalent, diabetes, peripheral vascular disease, carotid disease. And what I want to present to you today is that we have to be very simple, catch the problem, and see what can we do about it. And let me begin by saying that all the imaging technologies, in my own view, I think thus far are failing in really capturing the vulnerable plaque. And the question is why they are failing. And I'd just like to make 3 comments. First is a systemic disease. Second, the plaques are very abundant, those that may lead to trouble. It's not an autopsy, it's an in vivo. And third, not everything is a high-risk plaque. The blood may be hypercoagulable. Adding variables that make a patient to develop a thrombus that is not just a single plaque with fat that is going to explode. There are many systemic disease, and the mechanism of a blood clot is not necessarily plaque rupture in about 30 to 40% of patients. Now, I'd like to make a comment about each item. The first, this is a systemic disease, and to me it's very impressive when you do brachial endothelial vasoconstrictive studies or vasodilating studies, and then you find out that in patients with coronary artery disease who present, many of them with myocardial infarction, you might predict if they do well on the brachial vasodilation, they do very well clinically, and as you have constriction of the vessels in the brachial arteries, then you have significant more events. The point I'm trying to make here is a systemic disease, so there are many markers that are telling us that it's troublesome. And a simple marker is actually just looking at vasodilation, vasoconstriction in the brachial arteries. It's a systemic disease. The second is this angioscopic study. I like it, from Japan. You probably know of it, but I will summarize by saying that if you have a patient with an acute myocardial infarction and you open the artery and then you go with your angioscope, the chances is in that artery you are going to see 1 or 2 more lesions that look very similar to the lesion that led to the heart attack. And if you now go to the other 2 arteries, you find 1 or 2 more. What I'm really saying to you, we are dealing with the tip of an iceberg. And within the coronary system, there are a number of these plaques. Final comment is just to be sure that we understand how things change rapidly. About maybe 3-4 years ago, we used to say the carotid plaques that lead to a cerebrovascular event are very stenotic, very fibrotic, and therefore we cannot explain this by plaque rupture. Let me make the long story short. We were wrong. In fact, the issue is quite different. The plaques in the carotid arteries are 80%, but they have a lot of fat. The question is why in the coronary arteries the fat is in a plaque that is growing eccentrically, and in the carotid arteries the fat is in a plaque that grows concentrically. And now we begin to have some data on this, and that has to do with remodeling. The coronary arteries, as the plaque grows, the artery grows eccentrically. The carotid does not. So as the plaque grows concentrically, and you can have an 80% lesion with the fat and the rupture, and not necessarily is the 80% lesion in a coronary that tends to be fibrotic. I'm just presenting this to you because this all comes through the imaging technologies that are really telling us many things that maybe before we had wrong concepts. And this is just an example that what leads to a blood clot is different from region to region, but we were wrong in the way we interpret the carotid arteries. In fact, there is a lot of similarity with the coronary arteries. So we have to say from the high-risk plaque, we went to the high-risk symptomatic patient, and that we found that patient with many plaques, many mechanisms of leading to a blood clot, so we have to move on and say, I'm not getting anywhere. The next step is you move from the high-risk asymptomatic patient to the intermediate and low-risk patient. And I like to point out, because this is what your document is about. Your document has 5 layers here, not 3. Doesn't matter. But basically we are talking about the same thing, and that is we have to get away from the very top and begin to look in the bottom if there is something that we can be able to predict and maybe move on from the point of view of prevention or therapies. Having said that, I'm now going into what I consider is real business. and that is to go to all of these layers and to present to you what can be innovative that we may have an impact in the field in the next 5 to 10 years. And this is basically my discussion. And I will start actually from the top of the pyramid. I'd like to start from the high-risk symptomatic patient, and then I will move to the high-risk asymptomatic patient, intermediate risk, low risk, and I will make a comment about your organization here. So let me begin to go to the high-risk symptomatic patient. And the issue is the following. We are on the top, and now we are trying to do something about it. Myocardial infarction, number one. The time for the patient from chest pain to go to the hospital and being reperfused in this country is an average of 3 hours. Maybe in 10 years will be half of it, and there are ways to, the prediction is probably correct. What I like to make a point today, constantly I will make it, that if we are not simple, we will not prevent this disease. And simplicity to me is the name of the game. Complexity you don't lead anywhere. Marketing is always simple. You talk to marketing people and they will tell you at the moment you make a drawing that is complex, forget it, nobody will follow it. Based on this, let me predict what is going to happen in the ambulance in a few years from now, and as the patient develops a myocardial infarction. And this is again is a prediction, and the data is evolving. Today we are giving aspirin, isn't it? At the moment the patient has chest pain. This is a drug that is better than aspirin. It's a thromboxane blocker specifically, which permits prostacyclin to work. Aspirin blocks prostacyclin. You need a 40 milligram dose. Thromboxane receptor blockers are coming very rapidly, and those of you who are in the field, you probably are grasping this in the last year or so, and I don't have much more to say. Clopidogrel is a tough drug because it works through an intermediary. It goes into the receptor of ADP, and then an intermediary do the job, and you do not dominate the drug. But there are new clopidogrel drugs, actually we'll talk about this tomorrow, which are very direct, you can dominate, and maybe as effective as clopidogrel, but at least you can dominate the drug much better. You go to the hospital and then you start injecting heparin. I will tell you that the data evolving with oral factor Xa inhibitor is as good or better than subcutaneous low molecular weight heparin or intravenous heparin and fractionated heparin. Then you have the statin. So you have a patient in the ambulance, has an acute coronary syndrome, has been diagnosed through whatever EKG at a distance. You give a single pill. And this single pill or polypill contains all the ingredients. Now the patient is at a high risk. The ST depression is all over. The question is, well, needs 2B3A. I like to make a comment about 2B3A. In my view, maybe biased, I believe oral antithrombotics will take over 2B3A. It blocks the penetrator on the receptor of thrombin, that is very important. It's a drug that you dominate, and I can envision the treatment of a myocardial infarction with a pill, not with intravenous stuff or drugs, absolutely in the ambulance. I have to tell you, you might prevent by doing that at least 25 to 50% of the deaths that happen with myocardial infarction, which is in the first 3 hours. And I'm just presenting this to you what simplicity means. Simplicity means you can do anything you want once the patient is in the hospital. You have to go ahead and do something very simple. And this is evolving very rapidly, which is oral therapy, and I believe will be in a single pill. This is my, at least my view of seeing that problem. There is a second problem. Now the patient has chronic coronary artery disease or has coronary artery disease equivalent. The same thing. Patients, you know, after 2 years of a myocardial infarction, only 15% are doing what they are supposed to do. Taking the pills, taking care of their risk factors. Again, I think this is going to evolve on a completely different single pill. It's the single pill that you give for chronic disease, which will address the issue of compliance. And I'm just presenting, sure, somebody saying, well, the dose of a statin, forget, will be 3 pills with different doses of a statins. All these things are small things. The important is the concept. We have to move into simplicity. And this applies to the patients who are now, I'm discussing, are the high-risk patients. So that's basically my point of view. At the moment that we all struggle about how we identify the patient, I'm just thinking, well, once it's identified, let's do something that can work very rapidly. Now I'm going to move into actually the patient who never had any symptom or any symptomatology. And I divide not in 5 layers like you do, it's divided in 3. But anyway. And here's what it comes, this term which I like very much, is the burden of atherosclerotic disease, because bad is very bad. So that it just fits, again, for simplicity. Let me begin here by talking about this group. This is a high-risk asymptomatic, A means asymptomatic patient that maybe has subclinical disease. And you know what you do these days. You go to Framingham and you look at all the risk factor profile and you end up with a very high score, which puts the patient in a 10-year deal, which is of a significant more than 20% events at 10 years once you do the score. I'm not going into the details of this. We have been interested in imaging for some time. My interest in imaging has more to do, frankly, in understanding disease than they're just giving us an diagnosis right away. So you have to understand where I'm coming from. I'm not going to start giving you this CT is better than MR to see the 90% lesion. Actually, that's not my talk. I'm just more interested in see how we get into the mechanisms that we can make some difference into the patient. Okay, this is technology that I think that he will discuss this, which is really you measure the atherosclerotic burden, in these cases into the aorta, and you present this in square millimeters. And this is a study with actually 42 patients were in Framingham with different Framingham scores at 10 years. But the bottom line was the following, and here is where I am with you. What happened here is when all the patients were looked at, some had coronary disease, some not, it didn't make a difference into the Framingham score. You couldn't predict who had coronary disease, who didn't. However, when you look at the score of the MRI, it was highly predictable, pointing out what you said before. If you see the disease directly, in this case is in the aorta, you can predict much better if this coronary artery disease or not than if you go to a Framingham score. So in a way, this is a reality that is to look directly at the disease. There are many other ways to assess this indirectly, and I know you are very high on this, which is the carotid intimal medial thickening, and certainly there are studies done that show that there is some merit on that in terms of showing incidence of coronary events, progression or regression of disease. And I don't want to go into the details of the arbitrary study, how niacin in non-diabetic, non-metabolic syndrome, and when attached to a statin, can actually decrease that particular parameter and perhaps has implications in coronary disease. So there are other ways to go indirectly. What I presented to you a minute ago, which is to look at the burden of disease, is going to be applied in a study we are starting actually in a few days, a freedom trial of diabetic patients with multivessel disease, surgery versus stenting, eluting stents. But what we are going to do actually is bad. And that is how the disease progresses in the diabetic versus the non-diabetic patient. And if we treat the patients aggressively, risk factors, not whether you do stenting or surgery, this is aside, maybe we will convert the diabetic patient into a non-diabetic patient, but we have the technology to really look at this, and that is to follow the disease directly and to see how you manage it. And I think that's what is appealing of this. So I like just to mention that certainly MR technology, by looking in the way I discussed, can be certainly diagnostic of disease, of systemic disease, and can have implications in the coronary arteries. But again, the issue is not only diagnosis. What about treatment? And here comes the second item I want to talk about for a moment, and that is the studies done in the carotid arteries. What was done in 2005 is probably much better than what we did in 1999, which is to do MRI of the carotid arteries and to really characterize the disease with magnetic resonance imaging. Our study was after the specimens were taken out by endarterectomy, and there is no difference the way you see the carotid arteries in vivo and as you can see after you take the specimen with endarterectomy. But certainly points out the importance of what we began to work with Sahi in 4 years ago, which is to begin to look at plaques in the coronary arteries in terms of identifying different types of tissue. And this is tough, but it will come. I'd like just to point this to you because now